Very good afternoon to one and all. This paper was presented in Telangana last year. I updated the data and to my surprise, the results hold even after 1 year of surgery. So minimally invasive glaucoma surgery are procedures and devices, not just one surgery, which are usually with small incisions and blebless, can be categorized in many, many ways, but what I like to see it as outflow procedures and inflow procedures. Inflow meaning reducing the aqueous, outflow, there are several procedures. What the good thing about MIGS is that it utilizes natural physiological pathways like the trabecular meshwork, like the ciliary process, and the suprachoroidal space. The outflow pathways, they are said to open up dormant collector channels, especially in the infranasal area. This is limited by the episcleral venous pressure, and so very low IOP, it is said, cannot be achieved. And so it is effective only in early disease. So I set about to investigate the safety and efficacy of combining outflow and inflow MIGS procedures with phacosurgery in advanced primary glaucomas and compared it with the current gold standard of phacotrabeculectomy. This is a retrospective study in advanced primary glaucomas who underwent either combined MIGS procedure or TRAB MMC along with phacosurgery. Primary outcome measure was IOP greater than 5, less than equal to 15 millimeter mercury, and secondary were anti-glaucoma medication, total success, complications, and interventions. The combined MIGS procedure was all done under subtenons anesthesia, sterile conditions. First, temporal paracentesis was done, and the patient was positioned, so was the microscope, and under intraoperative gonioscopy, the KDB was done, followed by phaco in normal position, and then after placement of the IOL in the bag, the endoscope was introduced into the sulcus, and as you see, ECP was done. Where phacotrab is concerned, I did all under injected mitomycin C. They were then shifted to the OR, and they were mostly topical surgeries with usage of non-preserved lidocaine during surgery. I did superior site, separate phaco and trab. First, a rectangular flap was raised, then a clear corneal phaco was done adjacent to it, which was then sutured, and then trab was completed. The preoperative characteristics were pretty similar in both the groups, except where the IOP was concerned. It was slightly higher in the phacotrab group, and preoperative visual acuity, which was better, slightly better, in the combined MIGS group. Both procedures were very effective in reduction of IOP and anti-glaucoma medication and improvement of visual acuity. But when we compared between groups, what I found was the combined MIGS group actually had slightly lower IOP with lesser standard deviation compared to phacotrabeculectomy, though this difference was not statistically significant. Anti-glaucoma medication also was slightly lower in the combined MIGS group, but this too was not statistically significant. What was statistically significant was the difference in the recovery of vision. It was better in the combined MIGS group. Complete success was no different between the groups. However, total success was better in the combined MIGS group. Failure rate much higher in the phacotrab group. So was the serious complications defined as sight-threatening complications as well as visual acuity worse by more than 2 lines. Interventions also much higher in the phacotrab group. So combined MIGS is combining inflow and outflow. It seems to have an additive synergistic effect akin to combination anti-glaucoma medications that we commonly use in our practice. It can achieve a low target IOP in a safe manner. The role of episcleral venous pressure, including that of the collector channels, still remains to be answered. So combining inflow-outflow MIGS is in the least non-inferior to the current gold standard. It is safer, it has better preservation of vision, avoids all BREB-related issues with lesser number of post-operative interventions. Of course, larger studies and longer follow-up are recommended.